Welcome to the Med Madness podcast, where we dive deep into essential topics in medical education. Today we're focusing on a crucial aspect of obstetric care: preterm labour and preterm birth prevention. Preterm delivery, defined as delivery before 37 weeks of gestation, is a leading cause of neonatal morbidity and mortality, making its prevention and management vital for improving neonatal outcomes. Let's begin by discussing the risk factors associated with preterm delivery. The most significant risk factor is a history of prior spontaneous preterm delivery. Additional factors that increase the risk include tobacco use, multiple gestations, and prior cervical surgeries, such as cold knife conization. This procedure, performed to treat cervical intraepithelial neoplasia, can lead to cervical shortening and scarring, ultimately decreasing cervical tensile strength and increasing the risk of preterm labour. During the initial prenatal visit, it's essential to assess these risk factors to implement preventive measures. For patients with no history of preterm delivery, a transvaginal ultrasound to measure cervical length between 16 and 24 weeks of gestation is recommended. If the cervical length is normal, routine care is usually sufficient. However, if the cervical length is 2.5 centimeters or less, the risk of preterm delivery is high, and vaginal progesterone is advised to help prevent uterine contractions and preterm labor. For those with a history of preterm delivery, the management approach varies based on the nature of their prior delivery. If the prior preterm delivery was not associated with painful contractions, a prophylactic cerclage might be indicated. On the other hand, if the previous preterm delivery involved painful contractions, administering progesterone either intramuscularly or vaginally is recommended to reduce the risk of recurrence. Now, let's talk about the management of preterm labour, which depends largely on gestational age. When preterm labour is identified, the first step is to assess for maternal instability, intrauterine infection, or fetal distress. If any of these conditions are present, immediate delivery is necessary. If not, management strategies are tailored to the gestational age to optimize outcomes. For pregnancies less than 32 weeks, which we categorize as very preterm, several interventions are critical. Administering antenatal corticosteroids such as betamethasone helps promote fetal lung maturity and reduce the risk of neonatal respiratory distress syndrome. Penicillin is given to prevent vertical transmission of group B streptococcus, which is particularly important as preterm infants are more susceptible to infections. Tocolysis, typically with indomethacin, is used to inhibit contractions temporarily, allowing time for other interventions. Additionally, magnesium sulfate is administered for neuroprotection to decrease the risk of cerebral palsy. Between 32 and 34 weeks, categorized as moderate preterm, the approach includes antenatal corticosteroids, penicillin if the GBS status is positive or unknown, and tocolysis with nifedipine to delay delivery. Beyond 34 weeks, tocolytic agents are generally avoided due to the potential risks outweighing the benefits. Instead, expectant labour management is recommended, and antenatal corticosteroids may still be used, though their administration after 34 weeks is not universal. Patients who are Group B streptococcus positive or have an unknown status should receive penicillin prophylaxis. Let's illustrate this with a real-life case study. Consider Sarah, a 30-year-old woman with a history of cold knife conization for cervical dysplasia. During her initial prenatal visit at 12 weeks, her obstetrician noted her history and scheduled a transvaginal ultrasound at 18 weeks to measure her cervical length. At 18 weeks, her cervical length was found to be 2.3 centimeters. Given the short cervix, she was started on vaginal progesterone to prevent preterm labour. Despite these precautions, Sarah began experiencing regular painful contractions at 30 weeks. She was admitted to the hospital where her medical team administered betamethasone to promote fetal lung maturity, penicillin for GBS prophylaxis, indomethacin for tocolysis, and magnesium sulfate for neuroprotection. Her contractions were successfully halted, allowing her pregnancy to continue to 34 weeks, when she again went into labour. This time, the medical team managed her labour expectantly, administering penicillin due to her unknown GBS status. Sarah delivered a healthy baby boy at 34 weeks and 3 days with no complications. This case underscores the importance of early identification of risk factors and timely interventions in preventing and managing preterm labour. By understanding and implementing these strategies, healthcare providers can significantly improve outcomes for both mothers and infants. Thank you for joining us on this episode of the Med Madness podcast. Stay tuned for more in-depth discussions on essential medical topics. Until next time, keep learning and stay informed.